stage has been set. So we're going to now trod through the path of medicines, non-medical management, how, when, where, why. And we're going to start with a really good friend that we see each other more times a year than I guess he wants to see me. But so Dr. Adel Moiti, we've known each other for years in Texas and outside of Texas. And Dr. Adel Moiti is now, let's start with some of your degrees, because that's my envy. So he's a master in business administration with a focus on healthcare management, a master's degree in healthcare leadership at the University of Texas. He's a fellow member of the NAEC, but have really pushed the envelope on us thinking critically about how could we make business sense of all of this? How could we use what we know to facilitate better care for children and others? He's now a professor of child neurology at the University of Missouri in Kansas, endowed chair in neurology, chief section of epilepsy and clinical neurophysiology, and vice president of clinical access and associate chair. He's going to be speaking to us about fiscal savings. How can we make non-medical management make sense? And then we're going to be engaging with probably one of the most compelling components and needed components of epilepsy care, our neuropsychologists. Probably most important, but unfortunately at times most unappreciated or underappreciated. Dr. Dong is going to be is a pediatric neuropsychologist from Lowry, working with Sandy. Just met her yesterday, fortunately. Specializes in child and adolescent epilepsy. Did her education in California, at Palo Alto, and University of California. Fellowship trained, obviously, in neuropsychology. And she's going to be assessing quality of life. And how do we assess this, and how does it help? Then Sandy, we met at Texas Children's when she walked in one day without knowing me and saying, "Hey, dude, how do we take care of this kid?" Very typical Sandy. Knew even back then that she'd move on to great things. She's now division head of neurosurgery, Yeager Professorship in Pediatric Neurosurgery, professor at Northwestern University Feinberg School of Medicine, leading specialist in cardiovascular surgery, epilepsy surgery, craniofacial surgery. But I know her best through her work in outreach, engagement, looking at the underserved populations and really trying to address those populations locally, regionally, nationally. Uganda, is it? Yeah. And then later I'll bring up my other colleague who will moderate. I can start speaking about him now, but I'll wait a bit. So I'll ask the speakers to come up one at a time, after which he'll go back, and then we'll come up and have a panel discussion. All right? Dr. Adel Moiti.
Thank you, Dave. You presented me like I'm a businessman. Yeah, I don't have a dollar in my pocket. So. Well, it's a real honor to be here. Actually, I have to say that I owe it all to a man. I thought he was sitting in the audience, Steve Roche. There he is. So I owe it all to him, actually, when he saw me wandering the hallways of UT Southwestern 30 years ago. I was like, yeah, that guy can be a tall neurologist. He's crazy as he is. So. Okay, so it's very hard to follow Dr. Booth's great presentation. How much are we spending in the United States on healthcare? Any rough estimate? Healthcare in general. Then we're going to focus on epilepsy here in a minute. Too much. Okay, I don't have a dollar in my pocket, but for an extra dessert at lunch, any guesses? So anywhere between $3.7 to $5 trillion, which is about 20% of our GDP. Follow-up question, where do we fall among other developed countries in the world as far as outcome measures? Are we first, second, third? Where do you fall? Oh, come on, not last. It would be a shame. So we're number one as far as the amount of money spent on healthcare. We're number 11 when it comes to quality outcome measures. So there's a gap. And so we're going to try to focus a little bit and see how can we do better in epilepsy so that we can utilize our dollar right and yield some better quality health outcomes. Okay, so those are some of my disclosures. None of them will relate to this talk. So through this, I'm not taking you to Vegas, the city. I'm taking you to Vegas nerve. So this is a typo. I'm not sure how it happened. But we're going to go over healthcare in general. How are we spending our dollars in the United States? Where does epilepsy and where does neurology spending fall in this whole thing? And how can we do better by non-pharmacological therapies? And I'm not going to be able to identify the gap on all of that in 20 minutes, but I think we can scratch a little bit the surface. Where do we start? How can we get to that next step so that we can improve care in epilepsy while being able to direct the dollars into the right direction? By the way, I'm not going to touch on value-based care here because that's going to give people really, really a good sleeping aid. So this is across the United States. That's how much we're spending, and I realize it's a little bit small to see here, but as you can see, on the right, you see all the different, and I don't have a pointer, all the different disease state, all the different diseases by the different categories and the amount of money spent. In neurological, if you want to add a big portion of the musculoskeletal, we have actually one of the highest spending in the United States. We're higher for sure than cancer, the neoplasm that comes right after neurological disorders. If you look at, it's roughly about 50-50, a little bit more on the Medicare and Medicare, the government insurance compared to the private insurance, which also makes a big difference in the payer and how much are we collecting on the services provided to our patients. Then on the left, you'll see that the downbreak of that by age, and as you'd expect, the end of the spectrum. A little bit geriatric and somewhat early on due to the genetic and some of the metabolic and congenital disorders. That's where taking a lot of the money. But I really want to focus on the amount of money that's being spent in neurological disorders. And we're going to zoom in a little bit more into look at epilepsy. How much are we spending on epilepsy? And what's the dichotomy between epilepsy and drug-resistant epilepsy, which is a completely different disease, as everyone in this room knows. So this is kind of taken a little bit of a zoom in by age, where we know incidence of epilepsy has two peaks. The earlier peak is way early on in the first couple of years of life, and sure enough, it does correlate with the amount of spending that we're doing earlier in life. And the other peak that comes later on in life for a different set of reasons, with the neoplasia, the trauma, post-stroke, all of that at 65 and over years of life. Okay. Remember, we're doing that Zoom, Google Zoom, so let's come down to epilepsy. And there are a number of actually literature, a number of reports that has a pretty wide variability of how much spending. Some are taking only the direct care. How much are we spending on MRIs, ICU visits, ER, hospital and outpatient appointments? But others are taking into consideration some of the indirect costs. How much wages are lost? How many accidents are caused? So this is, when you add it all, the range is pretty wide. That reaches up to $60 billion annually in the United States. But I really like to highlight the difference between the two diseases, epilepsy and drug-resistant epilepsy. So there is about roughly, and this is only for direct costs, this is only for how much are we spending monthly, and you can multiply all of that by 12, per patient between epilepsy and drug-resistant epilepsy. So anytime I'm moving a patient from drug-resistant epilepsy closer to epilepsy, I am actually getting better saving. I'm redirecting that money that you saw in the previous chart into primary care and wellness, which falls way low on the chart. So we're spending a lot of money in tertiary care, but we need more development of vaccine and better control of weight and health so that I don't have to later on go ahead and spend that money on strokes and heart attacks and all of that. Okay, a busy slide that I really want to highlight a couple of things. So this is kind of lists where's the money being spent? What's the cost of epilepsy-related healthcare in care? And again, those are only the direct costs. We all know that epilepsy, it's no longer a comorbidity. Part of epilepsy is the anxiety, the depression, the migraines, the ADHD, all of those that will add to that cost. So this is only direct cost related to epilepsy. So this is looking at quarter by quarter, an average between all three categories of payers: the government payment, the private party insurance, as well as out-of-pocket and charity. So it's a range, but each one of those, they keep adding, and that's where that delta of almost $10,000 per month per patient when they have drug-resistant epilepsy compared to that just nice listening, behaving epilepsy, if there's such a thing. Okay, so let's talk a little bit about how can we save and what are the opportunities to save money? How can we make a difference? And it's really interesting. Years and years and years ago, actually, it was in Boston, the very first physician was actually a surgeon who tried to say, okay, let's look at quality and quality outcome measures. And by the way, he was fired. That was back in the 1920s. He was fired from his job because he was crazy enough to say, okay, saving money or reducing the cost will lead to improved outcome. And people thought he's crazy. But indeed, almost 100 years later, we're still proving that the wheel is circular. So healthcare costs and how can we really improve outcomes through epilepsy surgery, through neuromodulation, and through ketogenic diet. So this is looking at a cost-effective or the effectiveness of epilepsy surgery in drug-resistant epilepsy, either in temporal lobe or overall. And you'll see some great names here are really contributed to that area. So we know that even when I evaluate a patient for epilepsy surgery, and they don't end up having an epilepsy surgery, I'm saving money. I'm reducing the cost. There was last month a very good article in Seizure from Japan. That's why I didn't put it here, because this was really related to the United States. From Japan, showing that when I escalate the care of my drug-resistant epilepsy patient to an epilepsy center, I'm reducing the cost. Patient didn't get a surgery, didn't get a neuromodulation, they just went through the process. I'm actually reducing the cost by about 20% because I'm having better quality of care for this patient. So with epilepsy surgery, it shows effectiveness. So it's reducing per year about $100,000 in resources and in care. Also, we know that the evaluation of epilepsy surgery in 5% of patients who will not end up having a resection, it still saves that $100,000 per year. So how much does it cost to have epilepsy surgery? I'm not going to go in details in this because I know there will be another talk going over what's the path to surgery, but we all know the fork in the road. You either continue what hasn't worked, and that's certainly not the right answer, or move down the path. So this is how much it costs to have epilepsy surgery. It's roughly about $300,000 to $350,000, depending on the center, depending on the state, depending on what type of insurance, and so on and so forth. And that's the breakdown of what does that look like. Okay, how does that compare to medications? If I continue medicine, so that simulated model was done. If I were to continue the same medicine, or I intervene with the workup for epilepsy surgery, and either I have a resection or I don't have a resection, what does that look like? So in every one of the models, you end up actually saving, where it's always been in favor of having the surgery or even the evaluation to have the surgery, because I leave the clinic or I leave the process without a resection, but with a better plan. Neuromodulation, ketogenic diet, or even adjustment of my medications with some of the lesser side effect medications. I'm not going to call them different mechanisms of actions that will lead to cost saving. So point is, moving that pathway, that algorithm ends up saving money and ends up saving roughly about $100,000 annually. So what does that mean? So in 3 years, in both from the medical and the surgical standpoint, as well as from the social sentiment standpoint, within 3 years, I completely recover any penny or any money I spent in my epilepsy surgery, and now I'm saving. It's a negative rate ratio. On the other side, those who did not get their resection, those who just went through the evaluation and didn't get their resection, within 5 years, I'm now saving money and I'm advancing and I'm adjusting my cost. So this is where the two curves meet. 3 years for those who got resected, and in 5 years for those who did not get resected yet, we move past the process because I'm improving overall quality of life. So this kind of really to cap it for resected or for resective epilepsy surgery. We're saving about $100,000 annually past resection, even if seizures are not completely stopped. And again, like we just discussed, with the incremental cost effectiveness ratio, it's saving $31,000 per year for those who did not go for the resection. So in 5 years, I'm completely recovering that cost, and with an incident rate ratio, I continue to save that money down the road. Let's shift gears real quick and talk about some of the other non-pharmacological modalities. So neuromodulation, a study that probably everybody in this audience knows very well, late Sandy Helmers from Emory, looking at how much does it cost to have a VNS, and how long does it take to recover all that cost, and how much am I saving from there? So as you'll see in that bar graph, she looked for 6 months prior to implantation and look at how much does it spend to have epilepsy, and that's my 0. And after, with the VNS, with the surgery, with the follow-up for programming, I incur some cost. A year and a half later, I completely recover my costs, and anything after that, it saved money. So it reaches up to $60,000 annually. That saved money by improving seizures through VNS. I'm not seizure-free. It's a palliative therapy, but I'm improving my seizure, improving my quality of life, saving that money. Eleanor Bermanacum, very similar study on 43 patients, showing that reduction in the different healthcare incidences, from ER visits to ICU to hospitalization to ambulatory costs, I'm reducing significantly. So about same outcome. Within 18 months, I'm recovering 100% of my costs that I spent on my device, and now I'm saving in all those items here. Okay, what about other neuromodulation, RNS? So as you'll see highlighted in red here, this is the savings annually. So within about a year to a year and a half, I'm recovering my cost up to 2 years. Then after that saved money. So point is, every step I'm walking towards a non-pharmacological therapy, even by the evaluation, if my patient doesn't have the resection, or if my patient doesn't end up getting that complete seizure freedom, I'm saving money, I'm saving, because again, those are all indirect costs. It did not go over indirect costs from jobs, from social interactions, from mom and dad that have to stop their activities to be able to pick up Johnny from school, and the divorce rate and the social. So it keeps perpetuating. It's not just this amount of dollars. It really has the indirect cost, like I mentioned earlier, can be up to $60 billion, $60 billion annually just for epilepsy. Okay, so this actually put all 3 devices together. And again, very similar answer. So across the board, when we implant with any of the 3 devices, VNS, RNS, and DBS, with some differences, but the net result or the outcome is I'm saving money. I am actually reducing on those parameters, my ER visits, my hospitalization, my ICU visits. I'm reducing up to 80% from my baseline. So this is the percent saved. So you'll see that almost solid bar. That's for VNS, and the other 2 are combined together, DBS and RNS. So there's a little bit of a difference, a little bit in favor of VNS. However, all 3 devices are clearly cost effective when it comes over term, past the 18 months. It's money saved that I can now spend and go back and help not just my spending, but also my outcome measures. Okay, this is combining everything. This was a UK study. The cost-effective analysis of surgical and neuromodulation. So when I do it all together, and again, you see, and you know the same theme. Just putting some numbers to it. My incremental cost-effectiveness ratio significantly lower, but it varied anywhere from 3 to 61,000 pounds. So I continue to improve, and again, the cost adaptation, again relevant to in the United States, is roughly from $170,000 to $121,000. So this is as I adjust to the U.S. economy. And as I look at the per patient, per incident, it's around up to $120,000 annually by moving to either modality. So this is lumping everything, putting it together, and I'm now looking at, okay, how much am I saving, or what would the cost savings look like? So again, the surgical outcomes with improved quality of life, the reduction in surgical and pre-surgical evaluation costs, and the higher rates of surgical eligible patients. Again, just simply evaluating, even if they don't move forward to the resection, that ends up still saving about 20% of their baseline cost. We designed something kind of similar for ketogenic diet, which was a little bit hard because it's hard to convince insurance companies to pay for food. So this is where we looked at ER visits, we looked at hospitalization, we looked at outpatient visits, and very similar. Within roughly 6 months, you're saving. You start really significantly reducing the saving. And actually, in our cohort, it was 49% Medicaid, 51% insurance company. So again, very similar to what I showed earlier, the economy in the U.S. about 50-50. Okay, so how can we mitigate this? So this is a big one that will always start with education. There's a big gap in education. There's a big gap in awareness, and it starts with the primary care providers to community neurology, and even with a big responsibility is some of the societies and some of the academies to raise awareness for what's the algorithm to move patients down the road. So we looked at the use of virtual tools in narrowing impact and healthcare disparities in neurology, and we really was very, very specific, focused actually on epilepsy. Through the patient family engagement, with the different collaboration and partnership with the patient advocacy groups like the Epilepsy Foundation, the utilization of the PCP and creating that hub and spokes. We know that we don't have enough epilepsy centers. The recent article from the NAAC showed that, yes, we're having a little bit better, but we're not catching up with the prevalence of epilepsy in the U.S. So building that education, having those CME functions, being able to reach out and create that partnership with the PCP and the community physician. So it's my last slide, and actually I'm on time, which is weird. I'm a talker, as you can tell. So it costs up to $60 billion to take care of epilepsy in the United States as of today. Controlling seizures saves 50 to 150,000 quality adjusted life years. So I'm saving about $100,000 on average annually by moving the patient from I'm doing the same thing to I'm going to look into it, maybe do it differently. We looked at the neuromodulation and ketogenic diet that continue to save and continue to help improve. Even if I'm not completely seizure-free, just going through that process helps save that. Now I can turn around and say, I'm not as expensive healthcare, and I have a better quality outcome measures. Thank you very much.